Hello, and welcome to the final part of this nuclear medicine bone scintigraphy series. So today we're just going to talk about a few miscellaneous examples of SPECT CT which haven't really fit in anywhere else. So we're occasionally asked to perform SPECT CT to evaluate failing ankle replacements. Here's a planar image of a patient, and this has been performed 2 hours after the injection of technetium methylene diphosphonate. We've got an oblique view here of the patient's ankle, demonstrating markedly increased activity in the region of their total ankle replacement. Now, you might perhaps say that there's some activity here in the talar region, but it's quite difficult to localize it and actually work out what's going on. And that's why we usually perform SPECT CT routinely as a part of these studies, in contrast to knee or hip examinations for failing or painful joint prostheses, where we usually confine ourselves to a planar examination. So let's have a look at the SPECT CT on this patient. Here we are with the AP view. This is the normal side here, and we can see there's markedly increased activity at the talar metal interface, and also there's some activity more laterally. Let's have a look at that on the lateral view, but before I do, I might just point out to you that we really don't have much activity here at the inferior aspect of the lateral malleolus. So the activity here is rather centered around the joint. Here's that lateral view, and that's demonstrating markedly increased activity around the talar metal bone interface. And indeed, when this patient went to surgery, it was found that this talar component was loose, and it was removed and replaced. The other advantage we have when we're performing this examination, or one of the things we might be looking for, is can we identify degenerative change at other joints, perhaps the subtalar joint or the midfoot joints, because occasionally a total ankle replacement can alter the biomechanics in the foot, and the patient may develop rapid degenerative change at another joint due to altered loading within the foot. So if the patient has a painful joint, it would be very helpful to identify that, because if the problem is coming from another joint in the foot, a redo of the replacement would clearly be of no help. So we can see a nice subtalar joint here, no abnormal activity in that. Now you can do a high resolution image, which we have here, and you can notice that there's superior quality to this scan, so that's helpful if your camera has it. You can also do metal artifact reduction imaging with some scanners. You can see here we have quite a bit of metal artifact, beam hardening artifact. It hasn't caused too much problem here, but it can sometimes in prostheses. Now I just want to get you to look at this patient, another patient. Don't be worried about this lucency here, which you might see in the calcaneum. This is due to a transcalcaneal approach for the procedure. Obviously, if there's a lot of activity around here, you might suspect infection, but the lucency on its own is nothing to be concerned about. So this patient doesn't demonstrate activity at the metal bone interface, so the prosthesis is quite satisfactory. But if we look at an AP view on this patient, you can see we have focal increased activity away from the joint margins, and it's around this area of osteophyte formation here. And this is causing the patient pain, and this is what we would call gutter impingement, osteophyte formation pressing on adjacent tendons and soft tissues and pieces of bone rubbing against each other. And the surgeon can treat this by removing these additional pieces of bone, which is obviously a different operation to revision of the prosthesis. We would anticipate that revision of the prosthesis is not necessary here because we have normal activity. So here we have some preoperative radiographs on that patient. You can see the osteophyte formation here. The surgeon is lining things up just before the operation. And here's a fluoroscopic image afterwards showing us that this area has been cleared of osteophytes. And this lady did get a very significant improvement afterwards. Her ankle was a bit unstable, so she did injure her Achilles tendon afterwards, unfortunately, but it certainly improved her initial pain from this gutter impingement which she had. So this is one of the principal uses of bone scintigraphy in ankle prostheses. Is there an abnormality, i.e. is there increased activity? Is the activity around the prosthetic components, which may indicate loosening or infection? Or is the activity localized to an area around the osteophytes in the gutter area, as it's called, and they could possibly be treated simply by a localized surgical procedure. So that's your role in these cases. Moving on to another case, this is just a classic condition which is often imaged by bone scintigraphy. This young gentleman, I think, was 14 or 15 years of age and had pain for the last few months in his thigh. We can see here this very mature periosteal reaction along the lateral surface of the diaphysis of the femur, very much in contrast to the other periosteal reactions we saw in the previous videos where we saw aggressive or lamellated periosteal reaction types. And we also saw some periosteal reaction in other examples. So in this case you can see a lucency in the center of the area of periosteal reaction in the cortex, and this appearance here we might suspect that this was due to an osteoid osteoma, which nobody knows quite what it is, but it's some sort of fibrovascular proliferation within the bone which causes an adjacent periosteal reaction. Usually it has a pattern like this. If what we call the nidus, if the center of the osteoid osteoma is actually in the periosteum, just on the very edge, you can get a very aggressive looking periosteal reaction. But usually you get this mature pattern and recurring pain, often, as you possibly know, relieved by aspirin. That's the classic description, and occurring at night. So we decided to perform a three-phase bone scintigram on this patient. Don't see much of an abnormality here on the vascular phase. On our blood pool phase, however, we can see a focus of increased activity appearing in the region of the left proximal femur, indicating inflammatory change. And here on our delayed image, we can see a focus of activity just at the region where there was an abnormality on the plain film. Now, I'm afraid I don't have an example, but the classic appearance is of a double dot sign. So we can see, if I might just get a pointer here, we can see an area of a certain level of activity where the osteoid osteoma is. So we'll have moderate increased activity here, and then a more central increased area of density. Sorry, I'm not drawing this very well. A sharper area, so that's called a double density sign. Moderately increased activity here and intense activity here. But in some cases, in fact most of the cases I've seen, you just see an area of increased activity. And this is what you might see in an area this is what we might, the classic pattern for an osteoid osteoma. So we do have a CT image here, and this is showing just the same thing in greater detail. You can see the central nidus and the exuberant periosteal reaction around it. Here we can see it on our SPECT CT view, nidus, intense periosteal reaction, but of a mature type. Here's a conventional CT scanner, just like the image you saw earlier here. This one is a better quality, high resolution CT scan. And this is also showing us the nidus. Now, what you can see sometimes is an area of central calcification just in here, but we're not seeing it in this case. And here's the SPECT CT. You can see it localizes to the nidus. Okay, so that's all we have here. Just one final word about osteoid osteoma. It's treated by usually these days radiofrequency ablation, so a needle will be placed under CT guidance into the nidus and radiofrequency applied, and that will destroy the nidus, so hopefully the lesion will heal. And you can use bone scintigraphy to determine the success of the procedure if you wish, or you can just see if the patient gets better. Of course, if the patient has continuing symptoms, you could do another bone scintigram because it might be more difficult to interpret a CT after that. And it's critical to accurately localize the nidus so you know exactly where to place your bone needle for the ablation. And that's why the scintigraphy can be useful. So here's another example, just showing you why SPECT CT is very important and why we can't be satisfied in many cases with just using a planar image. This lady had metalwork in her lumbar spine due to a fusion procedure which was performed some years ago, and she developed low back pain, quite severe, so a bone scintigram was requested. A whole body scan has been performed, and you can see there's an area of focal increased activity in the lower right lumbar spine. Now, we've seen in previous videos this could be an osteophyte formation at the disc space margin, degenerative change in a facet joint. We really don't know, there are so many causes, and in order to help us further we need to do SPECT CT. So here we are with a SPECT CT examination, and we can see that focal area of increased activity localizes to the posterior elements on the right side. It didn't really localize to this pedicle screw. Of course, we would wonder had the pedicle screw been fractured, but we can just see the pedicle screw before on either side of this activity. In fact, on subsequent slices you could see the pedicle screw quite clearly away from the activity, so that was okay. And if you want to see if there's fracture of a pedicle screw, you can certainly look on this, and also plain films are often helpful in this regard. So there was a faint lucency here within the area of activity, but it's quite difficult to see. When we look on the CT only image, you can see, however, that there is a fracture here in the region of the posterior elements. And the patient had a high resolution CT scan through the area which confirmed this. So this is a patient who has a fracture in the posterior elements close to the pedicle screw, and that was considered to be the explanation for her pain. So this just shows you once again how SPECT CT, when used correctly, can help us to localize the site of a more general abnormality. And the way we can approach bone scintigraphy is to use our planar images to guide us to the target and then perform a SPECT CT of that area. If we know in advance that a particular area is going to be questioned, for example, in this case the lumbar spine, then we can prescribe a SPECT CT in advance so the technologists and radiographers can just get on with it without having to discuss it with us further, and we can plan the list that way. And as I said, I think in the initial video, or perhaps I didn't, if we know we're going to perform a SPECT CT in advance, we often give the patient we often administer a higher dose of activity. So we might administer 800 megabecquerels of methylene diphosphonate instead of 600 megabecquerels. So that's pretty much the end of this series on bone scintigraphy. You know about as much as I do about it now, and I hope you've at least gained 1 or 2 points. I just wanted to finish by showing this picture of this gentleman, George de Hefsey, and he is, there are so many interesting things to say about him. He is worthy of a talk in itself. He had such an interesting life and did so many things, including winning the Nobel Prize and becoming a Fellow of the Royal Society. But I think what's most relevant in his work to the series of talks you've seen is his work on bone scintigraphy, because he is in essence the father of bone scintigraphy and possibly of the imaging aspects of nuclear medicine. It was he that developed the tracer principle, which is so obvious to us today, when he injected phosphorus-32 into rats and later cats. And he was able to observe the accumulation of phosphorus-32 within the bones of the animals, and also able to determine that it left the bones afterwards, indicating that the bones were dynamic living structures and not just solid dead structures on which the rest of our skeleton is built. And he was able to detect those using Geiger counters. So he's a very important figure in the development of nuclear medicine. So with that, I'll bring this series to a close, and I hope you enjoyed it, and if there are any deficiencies or comments, please make sure to leave them in the comments section. Thank you.